Well, good morning, everybody, and welcome. Welcome to our symposium this morning. I want to start on time. We have an ambitious schedule, and it's not just an ambitious schedule, it's a highly clinically relevant schedule, and I think you're going to really enjoy the topics that we've selected, and you're in for a treat for the two guest speakers that we have who are joining us this morning for this session. As an introduction, I am Roger McIntyre. I'm a psychiatrist here in Toronto, or I guess broadly in Toronto. We're in Mississauga. And I'm downtown at the University Health Network. And I'm also the chairman of the Brain and Cognition Discovery Foundation, which is the foundation that is overseeing this and many other programs around the world. And I wanted just to say a few words about the foundation and what we're trying to do and why we have programs like this, not just here in Mississauga, but last year we were in Asia, and as I said, different parts of the world. I've had the incredible privilege doing what I do, and the privilege that I have is entirely because of the patients and the families that we see who have depression and bipolar disorder. And over the years, I have had the opportunity to participate in fora, not just locally and nationally, but internationally. And I've often thought that what we really need is an opportunity to provide for healthcare providers what I think is the state of the art in not just neuroscience, but brain-body science. And I have, as you all have, the wish to give patients the best care, and the best care begins with having state-of-the-art knowledge. And as I look around the landscape, there has not been as many opportunities, I think, as we should have to have access to that knowledge, to be able to think about that knowledge, to result in behavioral change for our patients. And I think to provide the best of care for patients and families today, I think it is really an inexorable fact that one has to really be on the cusp of the art and the science of this, and it's changing so rapidly. So we set the foundation up. The foundation not only is in the education space, but also is an incubator for very novel and very different research approaches to treating brain-based disorders. And you're going to be hearing a bit later on this morning about a partnership with a new clinic that's opening up here in Mississauga that's going to be the first in Canada that's going to be offering rapid onset treatments for persons who are suffering from treatment-resistant depression and bipolar disorders. A couple other comments before we get going. You see the title, Diabetes, Mood Disorders, and ADHD, Brain Hazards and Implications for Improving Outcomes. Some may wonder, this seems like a disparate set of topics. Where's the organizational convergence? Where's the theme? Where's the motif? And you're going to be hearing throughout the presentations the motif loud and clear. It's going to emanate and surround. This is about brain capital. And we're going to be saying a lot about brain capital, brain function, human capital. This is the brain economy. And whether it is autism or schizophrenia or OCD or whether it's borderline personality disorder, you pick the mental disorder you choose. Each disorder converges on cognition and converges on brain capital. And over the years, I've always been curious why diabetes and obesity results not only in a higher rate of mental disorders, but broadly, how does it in fact result in such decrease or debase human capital the way it does? And so we now know diabetes and obesity metastasizes to the brain, and we are in the brain preservation business. We have to be, because this is a brain economy. And this is going to come together very, very nicely. You have bios in your handouts, I hope, of our two speakers. I'll introduce them shortly. Just a data glance is here. We're going to begin with my presentation, broad sweeping look at depression and bipolar. We come to a program like this, we want to hear about where's the science, but we also want to hear solutions. And what can I do differently Monday morning that will be impactful and will be received by patients as something different and something advantageous to them. We're going to cover that topic. We're going to move into the topic of ADHD and bipolar disorder. This is a very common co-occurring syndrome or syndromes, and we're going to be hearing a lot about that. We're going to move into the topic of diabetes and this metastatic process, this bidirectional metastatic process between body and brain, focusing on diabetes and obesity as the exemplar. Then we're going to move into this very hot topic of ketamine, ketamine-like therapies, rapid onset therapies broadly, Where's the science on this? There's been a lot of talk about this the last 5 to 6 years, and I'm going to introduce the clinic, which just has received CPSO's blessings after about a year or so in development, and we are opening the clinic in about 4 weeks' time with first patients in. The learning objectives are here. We're going to talk about brain hazards, and the brain hazards are not just above the neck, they're below the neck. We're going to say a lot about human function, cognitive abilities. All of us in the room see persons who come into the clinics who are complaining of poor functioning, poor quality of life, and other patient-centric outcomes. That's what's driving this. How can we improve their overall human capital? Now, I want to direct you, if I can, to the website. This is www.bcdfoundation.ca. And on the website, we archive materials from this program, but also other programs. And you can be on the mailing list for that particular website. And I would encourage you to sign up. And as I said, you can have access to ongoing activities. They're fresh. And topics that are topical and are relevant and I think impactful. Okay, let's begin if we can. So the convergence of depression, diabetes, ADHD. David's going to take us through ADHD, and David's going to zoom us in and give us really the granularity, particularly disambiguating ADHD from bipolar and how we should be treating these common syndromes. I'm going to zoom out a little bit and give you more of the perspective than the precision, and I'm going to bring together the threads of mood, the threads of metabolism, and we're going to converge around cognition. Different organizations support what I do, and this is in fact a list of the conflicts of interest. And we need much more sponsorship from the private sector. Private sector is good for our patients, and it's a dynamic relationship. We need more of it. Okay, so we're going to talk about cognition. We're going to talk about depression. We're going to talk about the link. I'm also going to give you some solutions and some very new treatments that we have now available. So the way I think about this, seeing patients and families who have depression or bipolar disorder, I think about the public square. And the public square, in other words, what's happening not just across Canada and the other smug OECD nations, but just around the world. What's actually happening? What's happening is the shift towards the digital revolution. So the pop quiz is, when was the agricultural revolution, the first human revolution? 12,000 years ago. The second revolution was the Industrial Revolution over the last 200 to 400 years. And during that time, the agricultural and the Industrial Revolution, what occurred was something called the solo swan effect. In other words, as technology goes up, you see a commensurate increase in productivity as well as a commensurate increase in workplace opportunity. So in simple speak, Henry Ford develops technology, Henry Ford increases productivity, the entire state of Michigan is now working in the car sector. What's happening in the digital revolution has uncoupled the solo swan model, and Solow is a macroeconomist from MIT who won the Nobel Prize for this observation. The digital revolution clearly has technology pushing limits we've never seen before. There's productivity enhancement. Just ask some people who are victims of the robocalypse, how robots are taking over their jobs. And now what we're seeing is a decrease in workplace opportunity, and this is relevant to psychiatry. It's relevant to brain capital. Because to have a job, you have to have a skill set that's complex, that's cognitive and non-routine. Historically, it was simple. It was, in fact, manual, and it was routine. So if you're an actuarial and you look at psychiatry, or you look at disorders like diabetes, obesity that metastasize to the brain, the human capital implications are enormous. And that's always been a clarion call for me, that we need to have better ways to preserve brain capital, and what that really means in simple speak is preserving their cognition. Cognition is a broad concept. It is really a Copernican revolution of sorts in psychiatry, in the sense that we have spent the last 6 decades with DSM, going back to 1952, when DSM-1 was released by the APA Inc. We've had this fetish with dividing mental disorders in as many pieces as we can. Now in DSM-5, it's been a rapprochement of sorts, wherein we now, in fact, think about brain-based disorders along dimensions. And where they converge is on cognition. So this is on The column, assortment of mental disorders. Across the top are domains of cognition. What's the message? Mental disorders are cognitive disorders. So schizophrenia is a cognitive problem with reality testing disturbance. Bipolar disorder is a cognitive problem with mania. Depression is a cognitive problem with disturbance in hedonistic tone and disturbances in affect regulation. The list keeps going. And you're going to hear from Harpreet a little later on this morning. He's going to talk about the link between cognition and diabetes. So diabetes, in many ways, the portraiture is very similar to depression. It's common. It's going up. There seems to be a very long, lifelong pattern to many of these patients' illness course. But this is looking at cognition in diabetes. And cognition in diabetes is not just decreased, type 1, type 2. Type 2 is more common. But we see a deficit that's clinically relevant. And I'll say, Harpreet will say more about this. So as an academic, when you're interested in a domain that is so critical to health outcomes like cognition, and that is in fact right in the center of your crosshairs if you have depression or bipolar as a therapeutic target, and then this condition called diabetes or obesity has the same phenomenological dimension that results in debasing the human capital the same way. Through Socratic reasoning, you can then conjecture that there may be a convergent pathoetiologic nexus. And we've been looking at this, trying to unravel this. Who here likes completing insurance forms for your patients? Now, it's masochistic enough to get up on a Saturday morning and come here. But if you like completing the insurance forms, you got to be in analysis. I think you need to be in psychoanalysis. No one likes doing this. And you fill those forms out, and that line says, when's the patient going back to work? And you know you're just pulling that out of the deep blue sky. And what you put down there is just simply really your Walt Disney level creativity. You have no idea. Nobody knows. It's just all fiction. It's all just fiction. We have no clue when they're going back to work, but here's what we do know, is that we had our eye on the wrong ball. You see, the form says, when's your patient going back to work? And then they ask you to list the depressive symptoms. That is a waste of time because the depressive symptoms don't correlate with the function. And you all know that. You sit there with a patient in your office, their PHQ-9 score is a 6 or a 7. They've been off work for 3 years. The other patient's got a PHQ-9 score of 20, and they're taking the kids to soccer. They work 60 hours a week. So what we found in this study, this has been replicated, is what's driving function in depression and bipolar is not the totality of depression. Instead, it's the degree of cognitive problems they have. So to be kind of sort of short about this, it doesn't really matter how sad you are. What matters is how you can think. And how often do we assess cognition in patients who have not gotten back to work? Let me show you how this comes together in a cross-disciplinary way. So here's a study that was conducted. This study was led by one of our graduate students, Yenna Lee. And this was a study that surveyed just shy of 4,000 Canadians in the workplace. What was the question? The question is, why do diabetics have impaired workplace performance? Why do they have absenteeism? Why do they have presenteeism? And the rates of absenteeism and presenteeism are similar to what we report in depression. So patients complete a depression rating scale, they complete a cognition screener, they complete a functional scale, and some other metrics as well. What do we find? I want to draw your attention to 5 p.m. on that slide where it says workplace impairment. A lot of lines going in a lot of directions, lots of arrows. Here's the concept. You're not surprised to hear that people across Canada with pre-diabetes report a higher rate of depression. You're not also surprised to hear that people with diabetes in the workplace report not just higher rates of depression, but greater impairment in the workplace, as evidenced by more presenteeism and more absenteeism. So far, no surprise. Here's the zinger. When the analysis is conducted, what's determined is the reason why type 2 diabetics report impairment in the workplace vis-a-vis absenteeism or presenteeism is because of cognitive impairment. In other words, the same dimension that's affecting outcomes in depression is what's affecting outcomes in diabetes. And this is the proverbial calculus where 1 + 1 will equal 10. So when you have patients with depression and diabetes, or depression and obesity, depression and cardiometabolic syndrome, which represents 50 to 75%, These patients have a threat to brain capital. And this is exactly what's driving the poor health outcomes. Ben Goldstein's a very close friend of mine in Toronto. He's a psychiatrist, pediatric psychiatrist. Ben led a campaign with a group of us, and the case has been made. I just was in Connecticut the other day, and I saw the sign on the I-95 up to Framingham, and I started thinking, wow, that's pretty interesting. Framingham, the Framingham study. And we all know the Framingham risk factors for cardiovascular disease with diabetes and hypertension, obesity, and diabetes. Well, it's now known that depression and bipolar disorder are not associated with heart disease. They are risk factors on the same list as Framingham. They're tier 2 risk factors. And that's something we should be aware of. Therefore, every patient with depression and bipolar needs to be considered a cardiovascular risk because of the overrepresentation of the problem and also the premature mortality. But I want to stay conceptual just with you for a moment and talk about this bidirectionality, how the body metastasizes to the brain metastasizes to the body. This is a meta-analysis. It's a bit of an ugly slide. What's the bottom line? The bottom line is that if you have attention deficit hyperactivity disorder, you have a higher rate of obesity than the general population, kids and adolescents who are not being treated. Secondly, this adds to a growing body of evidence that ADHD, binge eating disorder, mood disorders, and psychotic conditions have higher rates of obesity. Why do persons with ADHD have higher rates of obesity? 2 reasons. They've got a cognitive problem called impulse control. Secondly, they've got a reward problem, hedonistic tone problem. And so we've been using this conceptual knowledge to try and direct us towards very new targets. Who thinks we need a 7th or 8th or 9th SSRI? No takers? We don't need them. And if you said we do, we're going to throw you out of here. We don't need any more SSRIs. We've got SSRI fatigue, okay? What we need is something outside of the box. And these are what we call targets. Sorry for the military kind of lingo, but these are targets. And this is a drop-down menu that we didn't have 5-10 years ago. I'm not going to cover this in great detail, but I'm going to pick a few of these threads out of the tapestry. And we're looking at scalable treatments that are ready on Monday morning that we can give patients targeting these systems. Many would know I have an interest in this space, this interface of insulin in the brain. And it's appropriate. Insulin was first used at Toronto Western back in 1921. This is the first patient, Toronto General Hospital, the UHN, that we're also interested in insulin in the brain. So for those who are less familiar, insulin is a neuropeptide. Insulin is responsible for neurotrophic activity, taking progenitor neurons, maturing them to mature neurons. It's also involved in neuronal plasticity. Neuronal plasticity is the basis of learning and memory. The other part, which is really interesting, is that insulin is an anti-apoptotic peptide. What the hell is that? Apoptosis is premature cell death. Depression, bipolar, and diabetes result in premature neuronal cell death. These are premature aging diseases. And insulin inhibits that premature aging process. Sounds pretty good to me. What's really interesting also is that disturbances in insulin homeostasis are implicated in not just depression, bipolar disorder, ADHD, binge eating, schizophrenia, but also implicated in Alzheimer's disease. You guys all know that 10% of all Alzheimer's cases are directly due to diabetes. 80% of Alzheimer's patients have insulin resistance. 80%. There's something going on here. We know that insulin resistance in the brain results in the deposition of amyloid protein. It results in hyperphosphorylation of tau. These are customers you don't want. Let's just look sideways. In addition to having these neurotrophic, neuroplastic, anti-apoptotic effects, insulin is also an antioxidant. It's also a monoamine oxidase inhibitor. And for those of you who are less familiar, insulin inhibits the Mayo enzyme that's located on the outer mitochondrial membrane. Under normal circumstances, on the left, insulin will inhibit Mayo at the right tonus, giving you just enough dopamine. If you have insulin resistance in your brain, that is, you have type 2 diabetes, or you have mood disorder, Insulin cannot inhibit the mayo. Mayo grows out of control like a weed, particularly this time of the year. And what happens is it catabolizes dopamine. And that's why diabetics and our patients with depression or bipolar disorder come to the office and say, I feel empty, I feel flat, I feel apathetic, I feel depressed, I can't focus, because they don't have dopaminergic tonus. And the dopaminergic tonus is relevant to cognitive functions, and it's relevant to the reward circuitry. And the disturbance in homeostasis and hedonism is the essence of mood disorders. Disturbances in homeostasis and hedonism is the essence of the brain consequences of diabetes. Okay, I'm going to give you a choice. The choice is you come to our clinic and you sign up for a study. Anyone know what our most favorite laboratory animal is? What's the most favorite lab animal for researchers? Rats? College students. You're right. They want the $50. It goes to the LCBO. That's their business. Okay, so we have patients. We have healthy controls. Healthy controls, given a choice of working hard at a task and getting more money in a variable ratio, or taking the easy way out on a task, getting a small reward on a fixed ratio, healthy controls will go for the more complicated task. That's called motivation, and that's reward. What this slide is saying is that as your insulin sensitivity goes up, you are more likely to go for the higher reward in a reward paradigm. If you have insulin resistance, E. G. type 2 diabetes or depression, bipolar, you actually have a deficit in both motivation and reward. They're very different. Motivation and reward are very different. So reward is very dopaminergic. Motivation is very cannabinoidergic and opioidergic. They're very different. One's called consummatory hedonism, one's called anticipatory hedonism. And both of these systems are affected in obesity, diabetes, mood disorders. So I often hear clinicians say to me, oh, that patient doesn't go for weight loss because they're so damn lazy. And I think, well, they're not really lazy. They actually have a deficit in motivation at the neurocircuit level. We can pick this up in paradigms. And along with that, we see decreases in trophic factors, not just insulin, but other trophic factors like brain-derived trophic factors, and an increase in inflammation. And this has been a very, very topical issue now, the emphasis on pro-inflammation. Because once you have depression or diabetes, bipolar, and even ADHD, you start seeing a tilt towards pro-inflammation, and that dampens down cognition and dampens down reward. Let's just summarize, if we can, where we're at. What we know is that depression, bipolar, diabetes converge at cognition. We also know that underneath the phenomenology, the lesion is driven by a disturbance in the circuits, the nodes, the networks. CNN, not fake news, but neuroscience, CNN. And the mediator is being driven by these metabolic peptides in many cases, and we think that's a relevant target. Let's get out of the mindset of conceptual, let's get out of the lab, let's get into the clinical ecosystem, let's talk reality again. How can we make our lives better for our patients? Let's start off with genetic testing. Lots of talk on genetic testing. I came back from the APA, the American Psychiatric Association meeting, on a flight Tuesday morning, Air Canada. It was on time, which is pretty rare. Tuesday morning, and a full page in the Wall Street Journal on gene testing and psychiatry. And what that told me is that there's a lot of people who want to make a lot of money off gene testing. And every company I meet who sells gene tests tells me that they're great. I was always told, don't ask a barber if you need a haircut. And so we've been looking at this data, looking at it very carefully, and I think there's a lot of confusion out there. We have about 30 genetic tests right now in the business around the world. The question is as follows. Can genetic testing as a decision support vehicle improve health outcomes in depression, and or is it cost effective? And the answer is to be determined. We still don't know. And this year at the American Psychiatric Association, there was a very large study, made it on CNN, made it on CNBC, made it in the Wall Street Journal, and it was presented as evidence that gene testing works. It turned out the study was a negative study. It missed its primary outcome. And so we have to be very, very careful. I had a patient in my office. This is why I feel very strongly about this. We all want anything, a test, that can guide us. I call it therapeutic Hail Marys. For those who follow football, all I'm doing is just throwing medications into the end zone. Hopefully someone catches it. Hopefully it works. We got to do better than therapeutic Hail Marys. So we all want a gene test, a blood test. But we don't want to be giving patients quackery. And I had a patient in my office about a year ago. She was devastated. And I was exploring why she was so devastated. And she said, well, I've been on all the drugs on the green bin. This is the drugs that were the gene test said there was right drugs for her. And they didn't work. And I said, yeah. And she goes, there's no hope for me. And I thought, I'm not going to try and argue with a depressed brain. I've done that 100,000 times and failed 100,000 times. But it really was a message to me that there are collateral damages when people are getting information that's not accurate. So this is still a technology whose time has not come, but maybe it will. There's some certain refinements, discussion for another day, how we can do that. Other parts is measurement. Now we keep talking about measure symptoms, measure the depression, the PHQ-9, measure function. I like the Sheehan scale. We developed a cognition screening tool and measurement tool. I believe strongly this is part of where we're going. This is where the puck is going in terms of how we should be assessing patients. I've always found in my career that cognitive testing, when I get the report back from the neuropsychologist, I have not found it very useful. It's like 30 pages long. I can't read the whole thing. I just read the last sentence. And it gives me some kind of just airy-fairy language. Moreover, patients don't want to always go for a 3-hour assessment. They don't want to pay for this. So this is free of charge. That's a good price. It's point of care. It's patient administered. And we really think, in fact, this could give you actionable information. We don't need more information. We got lots of it. We need actionable information. And if my patient has depression, diabetes, bipolar, their PHQ-9 score is mildly ill, but they're not going back to work, and the insurance company is saying, is this person scamming the system? They're not saying that. That's what they're actually asking you. And you need to understand that, I guess that could be in some cases, but I don't think that's actually very common. What's happening is that the patient has a deficit that's not being picked up, and we think that cognition can do it. So you can download this. It's free of charge. It's iOS. It's Android. It's on your smart device. Let me just tell you something else, which I think is kind of interesting. And you guys have been hearing a lot about apps and the role of apps in healthcare, and specifically in mental health care. So just to give you a bit of a kind of a topography, we have about 350,000 apps in healthcare. 350,000. We have around 30 to 40,000 apps in mental health care. We don't need more apps. What we need is apps that can make a difference in the detection, the diagnosis, prognostication, treatment selection. This is what's going to help us. People have been talking about apps as even replacing you and me as the healthcare provider. The so-called digiceutical. That's interesting. Now, I don't think it's going to replace us, frankly. That seems a bit alarmist, but it could certainly be a great companion. We've just finished a study, which I think you're going to find very interesting. This is what's called ecological momentary assessment, EMA. So EMA is an acronym you should know. My question is, do you want to see an animal in the zoo or in its natural habitat? The answer is obvious. My next question is, when you're assessing depression, bipolar disorder, any patient, do you think it's more accurate to see the patient every 2 to 4 weeks and then ask the patient to retrospectively recall what happened the last 4 weeks? Or is it more accurate and valid to have assessment of what they're doing every second of the day? The answer is obvious. Now, we have that capability because with an app that we've developed, we in fact can track patients' depressive symptoms. Now, this is, of course, is the surveillance world we're in, and I know we've got Cambridge Analytica and Facebook and all that. That being said, we can track whether you have depression. For example, location variance. If you have depression, you're more likely to stay put rather than see friends on a Saturday morning. How prognosticative is staying put for depression? In other words, to what extent does doing nothing on a Saturday predict that you're depressed? Next to nothing. It's got almost no predictive power. Okay, we can now track your social media, how often you're on social media. I can track your SMS texting. I can even listen to your voice and deconstruct it as a proxy of your cognition and look at the vocabulary as a proxy of your mindset. People with depression are much more dichotomous in vocabulary. Life sucks, life's great, rather than having shades. How predictive is that language analytic of depression? Not a whole lot. But when you start adding all these variables up, it's like pixels on a screen. The pixels all start coming in. And we can track your shopping, so be careful. We can track your banking. We can track your sleeping. We can track whatever we want to track. And we can proxy this to the 9 items on the polythetical list for depression. So we asked 200 persons with depression to wear the app for 3 months. And every 3 months, they completed the PHQ-9. And everyone knows the 5 is the cut point for being depressed, not depressed. So that's a binary outcome. And what we found is that the app could predict if you were depressed at about 91, 92%. With a sensitivity of 98% and a specificity of 93%. Psychiatrists like to think that they're better able at detecting depression than our colleagues in primary care. No, they're not. Our batting average is all about the same. What's the batting average? I just put this slide up in primary care. Same in psychiatry, you can see it. Sensitivity, 50%, 81%. That was a meta-analysis in Lancet a few years back. Conclusion. The app performed better than the clinician at detecting depression. This has been validated now, and we're now looking at this as a repeat change measure in another study. So it is not unthinkable that the future is going to begin to integrate some of this technology. It has to, just from the point of view of better care, better precision, and also it could help us get around the issue of access and availability. It's a conversation for another day. Maybe that the outcome in clinical trials should not be the Montgomery-Åsberg Depression Rating Scale. Maybe it should be an app. That's for the future, but something I thought you'd find interesting. Let's talk about treatment. Patient walks in the office, they have major depressive disorder. What is the treatment of choice? Well, it should be evidence-based. Manualized-based psychotherapy, CBT, behavioral activation, and IPT are first-line treatment strategies. If a patient has mild depression, I would say this is my treatment of first choice because the pharmacotherapeutic effects in milder depressed patients are not as robust when compared to those patients with more severe depression. You see mindfulness on there. Mindfulness is particularly effective as a relapse prevention strategy, but it's also effective as a primary strategy. Now, when it comes to antidepressants, we have really a surfeit of antidepressants. And this list, which I took out of our Canadian guidelines, is similar to the list in the United States. There are some suspects on here we don't have in Canada, like agomelatine. But we have a whole host of treatments. The real question is which one is the best or which ones are the best? And we don't really have an answer to that. All the antidepressants that Health Canada has approved have turned out to be effective. They have what I call the down payment. They've proven to be an antidepressant. But what's now emerging are differences between antidepressants in their dimensions. So everyone here who sees patients knows that, for example, bupropion is particularly effective for patients who may be, suffering from a little bit of maybe a bit of fatigue in some cases, and we use it sometimes as an antidote for sexual dysfunction, but which is not that great for. Duloxetine has very good efficacy in pain from different sources. Just 2 weeks ago, the United States Food and Drug Administration has allowed the companies that market Trintellix, vortioxetine, to put into their label that this is the only antidepressant that independently improves cognition in depression. So all antidepressants are not created equal. I keep hearing colleagues of mine say all the antidepressants are created equal. And I think to myself, that's not true. It's fake news. And then I think to myself, what's the politics of you and what's the politics of your message? Because it's not true. And we actually have differences between the agents now in efficacy. Fetsima is levomilnacipran. Antidepressant in Canada, it's a isomer of milnacipran. This is an NSRI. This is Canada's first NSRI, a norepinephrine serotonin reuptake inhibitor. And when we looked at the data, the company gave me their data, I meta-analyzed it, we found this drug is particularly effective for fatigue, lack of motivation, deficits in drive. And when you actually look at the data with a bit more granularity, the patients who have a depression and report significantly low MEI on the far left, what's MEI? Motivation and energy. Patients who are fatigued and tired. These patients are ubiquitous. These patients particularly did well on this particular agent, 60 to 80 milligrams a day. And these are very common patients, and these patients receive SSRIs, which don't help fatigue very well. Then they're pumped full of bupropion, and that adds additional pharmacotherapy. Sometimes that helps. But we need more tailored approaches for these patients. We did a post hoc looking at levomilnacipran because Strattera is a norepinephrine reuptake inhibitor for ADHD. Probably not the best treatment for ADHD, but it is a treatment for ADHD. But it really instantiates the notion that norepinephrine is pro-cognitive. What we did was we looked at levomilnacipran, some colleagues of mine and I, and found that Fetsima does have some ability to improve measures of attention, how focused you are and how much you can sustain it, which is in keeping with what we know about norepinephrine. Vilazodone has been in the United States for a few years. This is Vibrad. And one of the sort of secrets is this drug's available in Canada right now. It goes by the trade name Vibrad. And it's been shown to be effective in depression. And what's particularly important is this drug's been shown to be effective in depression and anxiety. And the company's waiting for an indication in generalized anxiety disorder. But the evidence supports its efficacy in GAD, a range of 10 to 40 milligrams a day. This is Vibrad, and this is a drug that we would prescribe for patients who are highly anxious with depression. So cognitive impaired patients, we got fatigue patients, we've got anxious patients. I'm going to talk about mixed patients in just a moment. What do you do when the index antidepressant is insufficient? The best proven strategies for add-on are atypical antipsychotics. So we have Abilify, Seroquel, Zyprexa, and more recently we have Rexulti. The challenge with Seroquel in Zyprexa is sedation and somnolence. Now, Zyprexa is just an obesity-producing drug, but Seroquel, two things happen. You gain a lot of weight or you don't. And so we don't know who that patient is a priori, so this is often a bit of trial and error. Latuda, lurasidone, has become not only a first-line treatment in bipolar depression, but has also become one of our go-to adjunctive strategies in patients who have mixed features. So I call it the 4 A's. Depressed patients who are anxious, agitated, angry, and have attentional problems. Anxious, agitated, angry, and attentional problems. Can you imagine being married to someone like that? Anxious, angry, agitated, with attentional problems. I don't think that's going to be a very happy marriage. Anyways, sorry for that little lapse. My little ADHD is acting up there. So Latuda is effective in mixed states, in MDD and bipolar depression. Rexulti is now in Canada, and this drug is being developed in bipolar disorder. But for now, we use it as an adjunct to SSRIs in depression, 0.5 milligram to usually 2 milligrams a day. Unlike Seroquel, there's less sedation. This drug does have weight gain, but not to the same extent, and it doesn't have the metabolic changes. So we have some additional agents. Now, we're in Canada. There's a drug called Vraylar, which is in the United States. It may or may not come to Canada. I hope it does. Rumor is it's going to come here. But I just put it in here because we often see a lot of patients who are cross-border buying their medications. And this medication has demonstrated efficacy not only in mania mixed and schizophrenia, but we've just completed a trial with this drug in bipolar depression. So patients, not infrequently, will go across the border, et cetera, down to Buffalo and so on. We have lots of patients at my center from the upstate New York area. And these patients, in fact, can now be recommended for Vraylar, but that's, again, not here in Canada. I want to just shift directions. So patients have depression, they have bipolar disorder, they're suffering from impairment in function. Job number one, treat the depression. We've got manualized approaches like psychotherapies, we've got pharmacotherapies. The first go-to strategy is with atypical, at least the first ones you think about. And the patient should be offered treatment that comports with the evidence. And we keep reading in the literature that only about 20% of people with depression and bipolar receive treatments that comports with the evidence. This is now a look at methylphenidate. And methylphenidate we've had for many years. David will say more about stimulants, et cetera, but this is a collaboration with colleagues in Taiwan that I've had for a number of years now. And the Taiwanese National Database is just a fabulous database. This database is known as the NERD, the National Health Insurance Research Database. Everyone in Taiwan is in one database. We've got everything on you. Everything, all your health statistics, all your vitals, all your demographics. An incredible opportunity to look at a population. We looked at methylphenidate in adults and in children. In the adults, we found that if you were on methylphenidate for attention deficit disorder, we replicated other studies that shown that we could reduce motor vehicle accidents. It also seems to reduce traumatic brain injury in the adults, and this is in children. You see, I keep hearing from the anti-psychiatry patient movement within psychiatry and outside of psychiatry that drugs are just toxic for patients. That's not what the evidence says. Carefully selected, appropriately employed, and deft usage of these treatments are life-saving. And this has been shown to have public health implications. Methylphenidate reduces traumatic brain injury in children and adolescents. It's also been shown to reduce bone fractures in children and adolescents, and we just reported that it reduces suicidality. Why? We don't know. We conjecture it's because of the anti-impulsivity effects. One of the canards, one of the false stories that was actually inculcated into my head when I was a resident was you never give stimulants to a bipolar patient. And like a lot of things in life, once you start thinking for yourself, you got to unlearn some of the nonsense that you were brainwashed on. Stimulants have a very appropriate role in select populations with bipolar. We did a study with Vyvanse showing that this drug was not only pro-cognitive in bipolar, but actually could reduce anxiety in bipolar. Reduce anxiety. Now, the question really is, who gets these drugs? I start off with who shouldn't get them. Patients who are hypomanic or manic should not get a stimulant. Now, someone will be saying, well, isn't that kind of axiomatic? Well, yeah, but a lot of our patients who are depressed, while depressed, also have hypomanic symptoms. Their mind's racing, they're distracted, and it's tempting to call that ADHD and treat it, and it might be, but if they have elevation, the stimulant's not the right treatment for them. But if the patient is stable on concomitant treatment and not hypomanic or having hypomanic symptoms, we find stimulants work extremely well. And the evidence is clear. This is a study from Sweden, an epidemiologic study. NMS means no mood stabilizer. MS means mood stabilizer. And what they're saying is if you add a stimulant to a mood stabilizer in an appropriate patient, you don't see destabilization. In fact, you see advantages not only in the ADHD outcomes, but also in the bipolar outcomes in the adults and kids. I bring it in now because we've been interested in stimulants for a long time. We use them off-label to target cognition in bipolar, apathy, fatigue, problems with cognitive dexterity. Foquest is a drug that we're using at my center probably more because it has a longer release. This is a drug that's methylphenidate. Patients are always complaining, my stimulant wears off by lunch, the adult patients. You know, by 2 o'clock, it wears off, and I want to have a higher dose. Maybe they need a higher dose, but often they need a different formulation. So we go with longer acting methylphenidate in the clinic as an adjunct in bipolar and MDD, 25 to 100 milligrams of Foquest. This is a study looking at this scale called the PERM-P, which is a mathematics test you do in a very kind of busy environment. It's a measure of how well you can focus. And what this is saying is that if you take this drug, you're benefited throughout 12 to 14 hours. So it's much, much longer acting than some of the other stimulant moieties we have. And we use this quite a bit in our center now as an adjunct to SSRIs and other antidepressants. Methylphenidate controlled release. This is just the kinetic. And I just want to put this in here. This is looking at the dosing of this medication. I think we come to meetings like this to hear something new. This is a newer stimulant to many in the room, FoQuest. And the value proposition here is that it can last longer. And I think that that's not just a claim. I think that's actually reality based on our experience vis-a-vis the adult is covered throughout the rest of the day, the afternoon and evening. And as you might guess, stimulants in depression and in bipolar are highly linked to favorable influences on weight. And that's not only because they reduce binge eating, but because, in fact, they have an effect on metabolism, both centrally and peripherally. So modafinil is a drug that we also very often prescribe in our patients with depression and bipolar. This is a study that came from Barb Sahakian's group in the Cambridge, UK, showing that modafinil, which is not really an antidepressant, modafinil is a pro-cognitive drug. Working memory is an executive function. Working memory is how many folders can you have open in your mind at the same time. And with modafinil, it seems to enhance working memory. And the translational value is that people with depression and bipolar often cannot function adequately because of a deficit in working memory. And modafinil has been very helpful, 200 milligrams to 400 milligrams in that regard. Let's say a few words now about other strategies, because this is, in fact, where we're going, some of these other directions. Lots to say about inflammation in the brain. Big topic. It'd be a 3-hour symposium. This, to me, is one of the most accessible proof of concepts. At our center in Toronto, we often are referred patients from the hepatology program who are candidates for pegylated interferon for Hep C. So the pop quiz for the residents is, what's the most depression-causing drug in the CPS or the PDR? And they often circle benzos, which is not untrue, but not the right answer. Propranolol, not the right answer. Alcohol, not the right answer. The answer is interferon. 50% of people taking interferon will experience clinically significant depressive symptoms. When you prophylax these people with antidepressants, you cut the incidence in half. Conclusion, inflammation is relevant to hedonism and affect regulation. 2, the street light has been shining on serotonin. We've had a high school crush on serotonin and dopamine for a long time. And I like a high school crush, but there's also things going on in the shade. And inflammation is also a target of these medications. This is kind of cool. Can you prevent depression? You sure can. Give people statins. Now, did you hear me correctly? Should we put statins? Everyone goes on a statin? That's not what I'm suggesting. What this is saying is that if you take statins, in this case, this was a patient population that had TBI, traumatic brain injury. And people, you may know this, people with TBI, along with having all the problems above the neck, they get problems below the neck too, because people with TBI have a higher rate of dyslipidemia. And there's an interesting physiology to this. And when you give people who are brain injured a statin, what happens is you correct the lipid, but you know statins are anti-inflammatory. And what this is saying is that if you have TBI and you're followed prospectively and you take a statin, what we find is that there's a differential effect on depression rates. Let me walk you through this. The slide on the left. This is the risk of depression if you have or you don't have hyperlipidemia. So we know that metabolism metastasizes to the brain. And we know that metabolism not only involves lipids and sugars, but also involves the mitochondria. So for 100 years, psychiatry blamed moms. Now we blame the mitochondria. The mitochondria. And we think that there's an alteration in energy biocapability. And so if you are dyslipidemic, you have a higher rate of depression, point number 1. Slide on the right, if you take a statin, you cut the rate of depression. Now, I'm not saying people should be on statins, but what I'm saying is this is a lesson. Is there something else that we can do in the general population that may not be a statin that could be prophylactic? Well, there's a poly pill nobody wants called exercise. That could be possibly the case. But you see here how inflammation is playing a role. Josh Rosenblatt, one of our PGY4 residents extraordinaire, minocycline. This is a drug we very frequently prescribe at my center. So we have a lot of psychiatrists here today who are seeing people later stage, more tertiary. Minocycline is not just a tetracyclic antibiotic. It's also an anti-inflammatory drug. And it does something really cool. It stabilizes the microglia. And why that's cool is because that's what lithium does. Lithium stabilizes the microglia, which are the macrophages of the brain. We found in our work, and this was meta-analyzed, that minocycline is an antidepressant. So we give minocycline 200 milligrams a day for up to 6 months for patients as an antidepressant. And we've been able to show through other research that it's doing it by normalizing the pro-inflammatory axis, making it back to its normal seesaw balance, which is pretty cool. I'll come back to the effect on the gut in just a moment. Josh went one step further and looked at all anti-inflammatory drugs. So I know it's a Saturday morning, lots of acronyms here. Omega-3 fatty acids, NSAIDs, N-acetylcysteine, pioglitazone. We have a whole assortment of anti-inflammatory drugs. Couple of messages, they are not interchangeable. It seems as though NSAIDs may interfere with antidepressant efficacy. Every clinician here knows that corticosteroids are not your friend when it comes to brain health. So all anti-inflammatories are not the same. Evidence does suggest that COX-2 inhibitors may be antidepressant. Low-dose aspirin may accelerate antidepressant action. Omega-3 has been largely a limp noodle, frankly. Omega-3 seems to have some potency in people who have elevated inflammatory markers. That is in keeping with the putative mechanism of action. So 2 grams of EPA doesn't really help depressed patients very much, but it may help those that have elevated CRPs. We're looking at biologics and a whole variety of other treatments that can target the inflammatory system. So are anti-inflammatory drugs promissory or are they prime time? They're promissory. They still need to be developed, but minocycline is probably ready more for the prime time. Delivering better insulin sensitivity seems to be pro-cognitive. We know this through exercise studies in rats and human subjects. I always like to tell the anecdote that when you take sugar in the afternoon and your mind feels a bit sharper after you had that nice sweet fix, that sweet fix is not because of glucose. Believe you me, you don't have a shortage of sugar. No shortage of sugar in North America. What's happening is when you take in sugar, you're getting a bolus of insulin. And then insulin releases dopamine and it releases acetylcholine. And that's why you're getting not just the reward, the hedonistic effect, but the pro-cognitive effect. And we've seen this in mild cognitive impairment. If you give intranasally delivered insulin, you can actually enhance cognition in MCI and Alzheimer's disease. And we've shown this in complicated cognitive syndromes like bipolar. Depression, don't know. Depression is a different entity than bipolar. We see a differential effect. But I tell my patients that we got to get you exercising. We got to get the weight off you. I'll talk about that in just a moment. So Rodrigo Manser is a psychiatrist at our center, and he led this campaign with Victoza. And Victoza, you know, is an anti-diabetic. And we know that Victoza is an incretin. And we thought, well, incretins are not just produced in the bowel, they're produced in your brain, in the nucleus tractus solitarius. And we know that it's involved in reward, in cognition. And so we wanted to test the concept that giving patients this anti-diabetic drug could be pro-cognitive in non-diabetics who have depression or bipolar. Now, I've learned over the years that open-label studies are always positive because you want the drug to work, the patient wants it to work, everyone's happy, and the patients lose weight, so they're automatically blind. This drug's a weight loss drug as well. Patients like that. So what we did was we looked at cognition. Patients' cognition improved with this drug. That was a very strong outcome for us. But what was also important is we looked at the brain with magnetic resonance spectroscopy. It's one thing for us to collude with the patients on on their metrics, but the brain started to show changes in this chemistry called NAA, N-acetylaspartate. It's a biomarker of neuronal viability. And that marched in the same direction as the pro-cognition. So 1.8 to 3 milligrams of Victoza has become one of the off-label drugs that we use in non-diabetics with depression and bipolar to enhance their cognitive performance. So you can see how this knowledge is hopefully changing what we do. So we're not just giving patients symptom-suppressing drugs, we've got plenty of those, but instead drugs that can possibly target the underlying disease state. Some of you may know that here in Canada, Contrave was just launched. Contrave is the combination pill of bupropion and naltrexone. And bupropion and naltrexone, everyone knows those two drugs, but they've now been combined together. Now, I know some of you have been doing it in your own labs, in your own garages, but now it's a pill. And this is indicated for weight loss in this country. And what's interesting as a pharmacologist about this drug is it's not just targeting the homeostasis of eating at the arcuate nucleus, but also the reward of eating. It's the only drug that does this. And it does it through a very complex interrelationship with melanocyte-stimulating hormone and endorphins. I bring it up because we're going to do a study with this drug, not in weight loss. But remember I talked about earlier that people who have insulin resistance begin to show decreased motivation and reward based on that paradigm? We're hypothesizing that Contrave, yes, it causes weight loss, but above the neck, it changes the homeostasis and hedonistic equation in such a way that patients, in fact, are less likely to crave in a maladaptive way. We don't want them to stop craving. Craving is a great thing. It's just craving a nice sweet is lovely, but you don't want to be craving 10 cupcakes. And so that's what we want to walk this through. Okay, remaining minutes, I want to show you something kind of cool. This is sirtuins. What the hell are sirtuins? Sirtuins are proteins responsible for premature cell aging and aging of the cells in general, and they're kind of a nexus of inflammation and metabolism. Why am I bringing up sirtuins? Depression, bipolar disorder, obesity, diabetes are conditions of premature aging. Nobody likes to be told that they look a lot older than their birth certificate indicates they should be. When you're told this, you don't like it, you get insulted. And we know that patients with depression and bipolar lose around 15 to 20 years of life because of the premature onset of age-related diseases. They also have a higher rate of Alzheimer's and other age-related dementing disorders. Give you some, these are rats. Most of us are not treating rats, but this is interesting because we know that in the rat model, you can make the rat immobilized. This is a paradigm for depression. And when you subject them to stress, the animal becomes helpless. When you sacrifice the animal, you find that its sirtuins went down. Now, the best way to get the sirtuins back up is to calorically restrict them. So here's another pop quiz. What is the most potent anti-aging intervention? Someone said it's oil of Olay. It's not oil of Olay. It's caloric restriction. Now, we have to eat, so do we have caloric restriction mimetics? We do. It's called metformin. It's called resveratrol. So resveratrol is a polyphenol within grapes and other berries and so on. It's in red wine. And resveratrol has been shown to inhibit a target called the inflammasome. And we think that this could reverse the injury at the metabolic and inflammatory level. And there's interest in looking at resveratrol as a pro-cognitive strategy in brain-based disorders. This is a study in mild cognitive impairment showing that resveratrol could slow down hippocampal volume reduction. Interesting observation. More work is needed, the usual line. The message is not, if you want to live longer, stop eating and drink red wine. The message is that we need to find novel targets. And the inflammatory metabolic target has been certainly very opportunistic. Carola Wrong, PGY1 at the University of Texas, she's been with us for the last year and a half, did a lovely review of cannabidiol. And just so you all know, THC9 is bad news. Bad news. It is a brain toxin. It is pro-psychotic in people at risk. It's anti-hedonistic. And it is severely, severely cognitively impairing. CBD seems to be a very different animal, and it may be pro-brain health. Study just in March in the American Journal showing that it could reduce psychosis, beat the pants out of placebo in reducing psychosis and schizophrenia. Cannabidiol looks very, very interesting. Is it ready to be recommended for patients? Not at all. So cannabis should not be recommended to patients with depression and bipolar, full stop. And cannabidiol is still not ready for the prime time, but it is promissory. I want to emphasize this point about body-brain. Bariatric surgery is powerfully pro-cognitive. And this is a study showing, one of many, that patients who are recipients of bariatric surgery evince improvements in cognition over 6 to 12 months. And the marker that seems to correlate with that improvement is changes favorably in insulin resistance. So the patients that we see with depression, bipolar, ADHD, certainly diabetes, that Venn diagram that we always see in our office, yes, we're going to give them state-of-the-art medication, state-of-the-art psychotherapy, but you can really see how the science is catching up with your intuition in terms of the need for weight management, the need for these types of other concurrent conditions to be managed. No business would be considered done till you talk about feces. So we're going to finish on feces. Hearing a lot about the bowel these days, the biome, the biota. What's the state of the art? And it is an art, sifting through feces, I'll tell you that. So what we know is that individuals who have depression or bipolar have decreased microbial diversity in their bowel. And the bowel is implicated, specifically the biota, the bugs, and the biome, which is the genetic material, in health and disease. And this has, in fact, been an observation that's been made in C. difficile infection. But if you're a victim of physical or sexual abuse, if you're someone who has sleep disruption, you also have disturbances in your gut. So the million-dollar question, what came first, the gut disruption or the behavioral disruption? And the answer is we still don't know. Is it now ready to give, time is right to give patients prebiotics, probiotics, and antibiotics to treat their depression? No. Minocycline, we are seeing effects. We don't know if it's actually through the bowel or not. I had a lady recently in St. Louis come up to me and she said, I give all my patients a gallon of yogurt a day. I said, she goes, what do you think of that? I said, well, I hope it's non-fat and non-sugar. I like a yogurt in the morning. It's very nice, Greek. But it's not ready for the prime time. And we got a lot we need to parse out here in terms of cause and effect. But I wanted to let you know we're looking at this, pre, pro, and antibiotics. And yes, fecal transplantation is being tested as an antidepressant. So let's summarize if we can. Patients we see are suffering. The outcomes are unacceptable. I look around my office. I see what patients are experiencing. I think this is agonizing, what's going on here. They don't need 7 or 8 more SSRIs. What they need is something different. And the difference begins with a framework, a strategic framework. And this, like every single idea I've ever got in my life in psychiatry, has come from the patients. And the patients are saying to us, I'm anhedonic, I can't focus, and I can't function. You want to call me ADHD, bipolar, depressed, diabetic, that's fine. But I am anhedonic, I can't focus, and I can't function. So we believe that targeting some of these newer systems are not just hopeful, but also perhaps disease modifying. And I certainly hope that they're not just symptom suppressing. I'm going to stop there, folks. Thank you very much for your attention.